Hi everyone, I'm Ana Tabalta. I'm currently a neurologist at Cemcat, and I'm a co-chair of the iWiMS Epidemiology Conference, together with Ethel Champi. And today we have two speakers, Carmen and Nicole Burjali. Sorry for that, Nicole. And we're going to start. First of all, we're going to do the two presentations, and afterwards we have the questions and the discussion. If you wanna, you can ask your questions at the end, or you can either write them in the chat, and we'll talk about them at the end. So we're gonna start with Carmen. Carmen did her medicine studies in 2001 in Rovira Virgili University in Tarragona. In 2006, she became a neurologist. She did the training at the Baltimore Hospital. And in 2012, she did gain the PhD at the Autonomous University of Barcelona, doing the research on primary and she did it at the Cemcat and the Queen's Square. After receiving a grant from the British Spanish Society, she did a master in medical statistics. And in 2015, she was awarded with an ECTRIMS postdoctoral research fellowship, in which she went back to the Queen's Square and did research with advanced neuroimaging methods. With all this knowledge gained during all these years, she came back in 2020 to the Cemcat after receiving a very competitive fellowship from the Junior Leader La Caixa, which is a really important grant. And she is now investigating mechanisms of damage and disease progression through neuroimaging data with advanced statistical models, including artificial intelligence. Carmen, she's a brilliant researcher. She has published more than 100 scientific papers, and she is in the editorial board of the Neurology Journal and the Multiple Sclerosis Journal. And today she's going to talk about the association of early progression independent of relapse activity and long-term disability. So, Carmen, whenever you want to start.
Thank you very much, Anna. Thank you very much, Ethel. It's a pleasure to be here, and it's a pleasure to share with you this work. I'm going to share my slides. Can you see my slides?
Yes.
Okay, great. So I'm going to talk about the association of early progression independent of relapse activity and long-term disability after a first demyelinating event. So these are our disclosures. So we know that in MS, there are two mechanisms for the accumulation of disability. So the relapse-associated worsening and the progression independent of relapse activity. And we know that PIRA, or the progression independent of relapse activity, is the main responsible for the irreversible disability accumulation in relapsing MS. As could be seen in this work, where between 80 and 90% of all episodes of confirmed disability accumulation occurred independently of relapses. However, at the time of designing this study, the presence of PIRA at very early stages of the disease had not yet been formally investigated. Also, the long-term prognosis of those patients who had PIRA was unknown, and the role of acute inflammation in the development of PIRA was not well understood. So based on that, we defined our objectives, which were to estimate the risk of experiencing PIRA after the first demyelinating event. Also to compare patients who developed PIRA at very early stages of the disease and those who did it long after 5 years. We also compared patients who had active PIRA and those patients who did not have active PIRA. So for our study, we included patients with a first attack who were 50 years or younger at the time of the first attack and who had been seen at Cemcat within 5 months of symptom onset. Also, for our study, we find some key concepts, such as the original study baseline EDSS score, which was the first EDSS score after the first 6 months after symptom onset. Then there was this concept of free relapse period. So this was the time between relapses. Then the re-baseline EDSS score, which was the first EDSS score at least 3 months after each one of the relapses. And there was the concept, the common concept of 6-month confirmed disability accumulation in the usual way. And then there was the PIRA event, which was the 6-month confirmed disability accumulation within a free relapse period. And the relapse-associated worsening, so the CDA outside this free relapse period. And for this study, we focused on the first PIRA event. Also, we defined early PIRA, which was that PIRA that occurred within the first 5 years of the disease. So this was what we considered an early disease. And then the late PIRA, which was that PIRA event that occurred after the first 5 years of the disease. And we also defined active PIRA, which was that PIRA where there was inflammatory activity in the MRI within the 2 years prior to PIRA, and then the non-active PIRA, which was that PIRA where there were no new lesions or enlarged lesions within the 2 years prior to PIRA. So for our study, we had descriptive statistics, baseline comparisons. We also looked at the risk of PIRA after a first demyelinating event, looking at those factors associated with the risk of PIRA. And finally, we looked at those long-term outcomes after the CIS for those patients who had developed PIRA as compared to those who did not have PIRA. And we focused on different outcomes such as time to EDSS-6, longitudinal trajectories, and annualized relapse rate. So going to the results, we had 1,459 patients seen at Cemcat with a first demyelinating event. Of those, we had 1,339 patients which conformed the deeply phenotyped CIS inception cohort. And out of this, we had 1,128 patients, which were those patients who had at least 3 EDSS assessments, because we had at least 3 DSS assessments to define PIRA or not. So going to the descriptive statistics, out of the 1,128 patients, 419, so 37%, had at least one episode of CDA. And of those, 277, which was 66%, had at least one PIRA event, whereas the 34% remaining only had CDAs in the context of RO. When we looked at the different classifications of PIRA, we had that out of those 277 who had at least one PIRA event, 86, which was a third, had an early PIRA event, whereas 69% had a late PIRA event as the first PIRA event. And then out of those 277, we had that 50% approximately had active PIRA and 50% had non-active PIRA. Going to the baseline comparisons, when we compared PIRA and no PIRA patients, we saw that PIRA patients were slightly older than non-PIRA patients. Also, PIRA patients had more brain lesions than non-PIRA patients, and PIRA patients were more likely to have oligoclonal bands at the time of the CIS. When we compared early PIRA versus late PIRA, we found that early PIRA were older than late PIRA patients at the time of the CIS, and also had more spinal cord lesions than late PIRA patients. When we compare active versus non-active PIRA, what we found was that active PIRA were younger at the time of the CIS. They also had more brain lesions and more gut lesions, and were more likely to have oligoclonal bands at the time of the CIS. Looking at those factors that were associated with the risk of PIRA after a CIS, we saw that out of these 1,128 patients included 277, which was 25%, experienced at least one PD event during the whole follow-up. And according to the Kaplan-Meier estimations, we saw that around 8–10% of the patients would develop the first PD event within the first 5 years of the disease, whereas 50% of the patients would develop the first PD event within the first 20 years of the disease. And when we looked at those patients with PIRA, the first PIRA event occurred at the time of 7 years, approximately after the first demyelinating attack. And when we looked at those factors that were associated with a higher risk of developing PIRA, we saw that only an older age at the CIS was associated with such higher risk of developing PIRA. And in this table, you can see a description of all the variables that we looked at. And as you can see here, only being older at the time of the CIS was significantly associated with a higher risk of PIRA after adjusting, of course, for confounders. When we looked at those long-term outcomes, we could see regarding the comparison of PIRA versus no PIRA, that PIRA patients had shorter times to an EDSS of 6, as you can see in this survival model, and also they had steeper EDSS increases than non-PIRA patients over time. And you can see here the same information, but in a table, and you can see that those patients with PIRA had almost 8 times higher risk of reaching an EDSS of 6 during the follow-up. And when it comes to relapses, you can see here that PIRA patients had fewer relapses than non-PIRA patients. When we compared PIRA versus RO, we could see, and this is an unadjusted analysis, so just a descriptive analysis. We can see here that PIRA patients had greater unadjusted changes in EDSS from baseline to last follow-up than RO patients, and of course, than no CD8 patients. And when we looked at the survival models, we could see that PIRA patients had shorter times to an EDSS of 6, as you can see here. And this higher risk of reaching an EDSS of 6 was almost 4 times higher for those patients with PIRA with respect to RO patients. When we compared early PIRA versus late PIRA, what we found was that early PIRA patients had shorter times to reaching an EDSS of 6. As you can see here, it was almost 30 times higher risk of reaching an EDSS of 6. Also, they had steeper EDSS increases, and they had similar annualized relapse rates. When we compared PIRA versus active versus non-active PIRA, what we found was that active PIRA had a non-significantly shorter times to EDSS 6 than non-active PIRA. And also active PIRA had marginally steeper EDSS increases than non-active PIRA and had greater annualized relapse rates than non-active PIRA. And these results are adjusted also for age, sex, treatment exposure, and also inflammatory burden at the time of the CIS. So to conclude, we can say that PIRA is not uncommon and is associated with unfavorable prognosis. Also, PIRA may appear early in the disease course, which means even a worse prognosis, which indicates that progression may be present from disease onset, at least in some patients. Also, predicting PIRA is challenging, so more research is needed since this may have therapeutic implications. And finally, the strong association between older age and higher risk of early progression after the first attack deserves further research too. So thank you very much for your attention, and I will be very happy to answer any questions at the end of the session. Thank you very much.
Thank you so much, Carmen. I think we will have many questions for you by the end of the second lecture. Remember, you can write all of your questions in the chat, or later you can raise your hand so you can ask Carmen your questions. Thank you very much, Carmen, and congratulations for your work.
You're welcome.
Our second speaker is Nicole Bourjaili. She is a postdoctoral research fellow in the Neurology department at Johns Hopkins University School of Medicine. She earned her undergraduate degree in biology with a special interest in neuroscience and her medical degree at the American University of Beirut in Lebanon. She moved to the United States to perform clinical research under the mentorship of Dr. Ellen Murray, and her research focuses on digital biomarkers of MS progression, predictors of misdiagnosis of MS, and optimizing the use of Ocrelizumab in MS. She plans to apply for a neurology residency program this fall, and her title is Extended Interval Dosing of Ocrelizumab in Patients with Multiple Sclerosis is Not Associated with Meaningful Difference in Disease Activity. Welcome, Nicole.
Thank you, and thank you for this introduction. Let me just share my screen. All right, can you see my screen?
Yes.
Okay, perfect. So thank you everyone for joining us here today. Those are our disclosures. And as you all know, Ocrelizumab is a disease-modifying therapy used for the treatment of multiple sclerosis. And it is usually given as a standard interval dosing of every 6 months. However, during the COVID-19 pandemic, there were concerns related to increased risk of COVID-19 infection and reduced COVID-19 vaccine efficacy. And so many clinicians opted to use an extended interval dosing instead. And so this time period provided us with an ideal opportunity to look for and determine whether extended interval dosing of Ocrelizumab is associated with changes in disease activity in patients with MS. And so for the study, we reviewed the medical records of all patients at our institution who were on Ocrelizumab and prescribed Ocrelizumab as of March 2020. And those patients were followed up until March 2023. Patients with relapsing remitting MS and progressive MS were evaluated for clinical relapses or the appearance of new lesions on imaging. And of course, we collected demographics, clinical data, and data related to Ocrelizumab infusion dates. So for our study, we used 2 cutoffs to define extended interval dosing. So the first cutoff was greater or equal to 8 months. And this was based on the literature review, where many studies had reported a median delay of around 8 months in their studies. And we also used a cutoff of more than or equal to 12 months, because this was a more significant delay that may be more relevant in clinical practice. And patients were classified as EID if they ever met the definition of infusion delay. That is, if they ever had at least 1 infusion that met the criteria of EID in our study. We had 364 patients included in our study. When using the first cutoff of EID greater than or equal to 8 months, we had 182 EID patients versus 182 SID patients. And while using the second cutoff of greater than or equal to 12 months, we had 73 EID patients versus 291 SID patients. This graph shows the frequency of infusions with intervals greater than or equal to 8 months. And although you can see that most infusions were clustered at around 8 to 12 months, we can see that some patients even had delays as much as almost 2 years. Now, the reasons for having an extended interval delay dosing were various, but the most common were related to COVID-19 concerns, and those were divided between those who fear and concerns for COVID-19 infection, as well as delays related to COVID-19 vaccinations. Those were 58%. And then 9% of patients had delays in their infusions because of pregnancy planning. 8% had delays because of infections at the time of their scheduled infusions. And then there were other less frequent causes as well. Now, when we compared the demographics and clinical characteristics of the SID patients versus the extended interval dosing of greater than or equal to 8 months, we can see that there were no really significant differences between the two groups in regards to age, sex, race, ethnicity, BMI, number of relapses prior to ocrelizumab, EDSS at initiation of ocrelizumab, as well as type of MS. However, we did find significant differences related to the duration of ocrelizumab treatment, where the EID group had more significant, or they were on ocrelizumab treatment for longer durations than those who were on a standard interval dosing. And when we used the cutoff of greater than or equal to 12 months, we actually had very similar results, where the only significant difference was related to duration of ocrelizumab treatment. Now, when we looked at the presence of disease activity in our whole cohort, so regarding clinical relapses, so none of the progressive MS patients had a clinical relapse versus 3 relapsing remitting MS patients who did. And then when we look at the presence of new MRI lesions, first of all, the denominator here is a bit different just because some patients did not have available MRIs in our study. So none of the progressive MS patients had new lesions on MRI versus 7 RRMS patients who had new lesions. Now, this graph shows the timeline of the 10 relapsing remitting MS patients who had experienced breakthrough disease. Now, just to orient you, so the x-axis represents the time since the start of treatment with ocrelizumab, and then each line represents one patient. The dashed blue line represents those patients classified as EID, as in those patients who had at least one delay in their infusion greater than or equal to 8 months. And then the orange line represents those who had a standard interval dosing. At time 0, all patients had their first ocrelizumab infusions, and then the arrows represent the subsequent ocrelizumab infusions. Now, if we look at the top 3 patients, those are the ones who had a clinical relapse throughout their treatment course. And those patients had new manifestations of their disease. So, for example, the top 2 patients had optic neuritis, and they had never had an optic neuritis event prior. And the 3rd patient had partial myelitis. Now, the remaining patients actually had a new MRI, a new lesion on MRI. And just to note that the blue dot represents the last MRI prior to the appearance of the new lesion. Now, if we start from the top, I'm not sure if you can see my cursor, but the top 2 patients in this group actually had a few months of ocrelizumab infusions prior to using an extended interval dosing, while the patients that are the 2 patients just under had only 2 infusions before using an extended interval delay. Now, just to note that the 2 patients designated with an orange asterisk, those are classified as EID. However, if we can look closely, we can see that they had actually resumed a standard interval dosing before having a new lesion. So it's not entirely clear whether or not the appearance of this new lesion was associated with this extended interval dosing or not. Now, so our study is a small retrospective observational study, and the decision to use extended interval dosing was based on the clinician's clinical judgments and may relate to perceived risk of breakthrough disease activity, which can lead to confounding by indication. Just as we saw when we compared the 2 groups previously, where patients who had EID were on the longer ocrelizumab duration compared to those with SID, and this could be maybe because physicians were more comfortable using EID in those patients who had a longer duration of treatment. Now, there was also lack of systematic MRIs for the entire cohort that may have also introduced bias, and CD19 counts and percentages were also not systematically collected for our patients. So in our study, we could conclude that there appeared to be no marked risk of inflammatory MS activity for extended interval dosing patients compared to those on a standard interval dosing of Ocrelizumab. And as future directions, so we are actually looking into neurofilament light chain levels to see if there are any differences between the two groups. And of course, larger prospective studies may be needed to confirm those results and to evaluate whether EID is associated with reduced risk of adverse events, such as infections, which is also an important aspect of Ocrelizumab treatment. And in fact, pragmatic trials of larger duration would help reassess the clinical effectiveness and the safety differences as well. And thank you very much. Feel free to ask me any questions. And this is my email if you would like to reach out to me after this meeting as well. All right. Thank you.
Thank you, Nicole, for the presentation. I think we have some questions in the chat. I don't know if you want, Emmanuel, to make the question yourself.
Sure. Thank you for great talks. So my first question is for the PIRA or PIRA, whatever you pronounce it. I think that there's a lot of I think we're mixing probably different reasons why there is progression. And I'm a little concerned that, some of these could be secondary progressive MS, some of it could be just aging with normal neurologic changes or comorbidities interfering with the measure we do with DSS, which is not perfect. So I'm not sure how to wrap my head around the notion of PIRA, and I really think that before we continue to say, well, we need to treat more aggressively or whatever, we need to sort out better what contributes really to the worsening, because seeing that cord lesions predict DSS worsening, so we know that. So is that really PIRA or is it secondary progressive MS? So I'm curious to hear what you think.
Yeah, I mean, thank you. And the truth is that we had a lot of discussions about this, and our mindset also has changed a bit over time. At the beginning, we were seeing this as a classical SPMS that started early, for example, in the context of single attack progressing, patients that we had seen this in the past, so this wouldn't be anything new. But then, of course, this is progression, that's for sure. I don't think this is aging. This is progression, and it's progression that starts very early in the disease course. So I think the question is, why don't we call this SPMS instead of PIRA? And it may be SPMS, but from a practical perspective, calling SPMS patients who have very, very short disease duration and who are not disabled is very, is a bit controversial, or at least the definitions of SPMS typically ask for an EDSS of 4 at least. So it's not that easy, and I don't think it's a closed issue. I think it's an open issue, and I think this deserves further discussion on how we can call that. But what I think is sure is that there is a proportion, which is not very high, but is not minimal either, of patients who develop progression early in the disease course. And we can call them single attack progressing, SPMS, or PIRA. It doesn't really matter. But I think the phenomenon is there. Normal aging, I don't think is normal aging, because we really see this confirmed worsening, which you don't see in normal aging. But it is true that this study doesn't have a control arm, which is followed up longitudinally, which would be ideal.
So when I said normal aging, there's normal aging in patients who don't have MS, and then the aging in who have MS. When we see patients in the neurology clinic who are in their 60s and they have little decreased vibration perception on their toes and they don't have MS, we think, wow, that's probably related to age. So there are changes that occur within the nervous system that can be more or less pronounced with aging, whether patients have diabetes, high blood pressure, or other things. Because you clearly show that what you call late PIRA is occurring on average 22 years after onset. So that means there's really something about aging, right?
Yeah, I mean, I think the late PIRA is what we all, I think, or almost all have in mind as SPMS. What is not exactly as SPMS is the early phenomenon of PIRA, which is not that common. But what we found was that this was associated with long-term, unfavorable outcomes, which was, the key thing. Yeah, I agree with you that we don't know exactly what's going on there in terms of the pathological substrate. So why these people, as I was mentioning my conclusion, so why there are some people who have this early phenomenon and why there is such a strong relationship with age. I think we cannot answer this, and I agree with you that this deserves further research. I don't know. I think Ellen had some comments.
Yeah. Hi. Thanks. These are really tough concepts to struggle with, for sure. A couple of thoughts. One, I worry when you're looking at like dividing people into PIRA and non-PIRA, and then you're saying PIRA is associated with subsequent progression, that's sort like a little bit of an incorporation bias, right? Because you're taking people who have already started progressing, and then they're more likely to progress. But the other thing, just to follow up on Emmanuel, because I think she's heard me give this talk about like how are we separating like aging from and related constructs that occur, right? So if you read Sharon Lynch's cross-sectional study, but a kind of interesting study that she published over a year ago, where she looked at people with and without MS over the age of 50, blinded EDSS exams, and saw a pretty reasonable distribution of EDSS exams. So, I think obviously it requires longitudinal follow-up and trying to understand younger cohorts, that sort of thing. But it really does demonstrate that like we do have to be careful in trying to parse out, how people acquire neurologic exam changes over time, because with this increasing push for like using stronger medications and things like that, we could end up harming people by, treating them aggressively in a way that's not expected to produce improvements in outcomes.
Yeah, thank you. I mean, it's true that, in my conclusions, I was mentioning that this may have therapeutic implications, but to be honest, I don't know exactly what implications this may have. For sure, this might have in future once we discover, I don't know, there is an interference or it's my computer, which is going crazy. But, this might have or may have therapeutic implications, but maybe these implications are not exactly to treat more aggressively. I didn't mean that, but I agree with you. I mean, a lot of questions to be answered in that regard.
Okay, I think we have some other questions in the chat. Helen Tremlett, which is having technological problems.
Sorry, I don't know if the first
I
don't know if the first speaker covered this or not. Sorry, but just interested because we struggle with considering disease-modifying drug use over time in some of these studies. If you covered it, no need to repeat it now, because I did lose contact for a while. But I'm curious, were you able to adjust for disease-modifying drug use? How did you do it? Any lessons learned? Did you find anything? Any lessons learned? Or how would you do it differently in the future?
Yeah, thank you, Helen. We adjusted, or we accounted for treatment exposure, but we did not focus our analysis on that, and this is a limitation of the study. So basically, we had two approaches to account for treatment exposure. One, and I didn't cover that because I didn't have time, but one of these approaches was to adjust for treatment as a time-varying covariate in the survival models. So as a binary event, either you start treatment or not, and then, without putting any other effort on distinguishing between first line and second line, whatever.
So you go 0, 0, 0, you start drug, and then you're 1, 1, 1, 1.
Exactly. As a supplementary analysis, we performed the same for the second line drugs, and things didn't change. But our main analysis was just accounting for treatment as a binary event. Whatever treatment you started, we didn't focus on that. This was one approach. And the second approach was in the mixed effects models. We adjusted for the percentage of time on treatment, which is not maybe the best way to do it, but at least we had an idea of how much exposure of treatment this person had had. We didn't do any.
Was that in the Cox? Sorry, was that in the Cox model then? That second adjustment.
In the Cox model, we accounted for treatment as a binary event, as a time varying covariate. Exactly.
So it was mixed models that you did the percent proportion. Is that weird in that? Is that odd in that the longer you follow someone, that's going to influence the proportion of time they're on drug, which may have no relevance to the outcome?
Yeah, I mean, this was a risk, and we acknowledge that. But at least we had an idea of how much exposure this person had, without going into details or any adjustments of, for example, for disease duration or things like that. Yeah. But I agree with you. Now, actually, we are working on better models where we account for these treatment effects in a much more detailed way. Yeah. I have to say that when we adjusted our models for a treatment exposure, we did not have any significant effect, any significant change on the estimates. So the estimates remain the same in our analysis. Yeah.
No, it's a tough one. Sorry, it's something that my group discusses all the time, and we're trying to figure out our models. So yeah, okay, thank you.
Yeah, no, thank you for the question.
Thank you, Helen, for your question. Emmanuel has another question for Nicole. I don't know if you want to...
Maybe we should finish the discussion on PIRA, because I see there's another question on PIRA from Elizabeth.
Okay. Yeah, there's another question. Would you think that there are more early PIRAs that are more common if we consider also cognitive changes? What's your opinion on that?
Okay, is early PIRA more common than we think? That's a good question. I think this was a bit of a surprise to us, because we did not expect to have this presence of early PIRA, which we believed after looking at the long-term consequences of early PIRA. So we believed that. At the beginning, we were a bit cautious and reluctant to think about that. And then, is this more common than previously thought? I think yes, although it's not super common, but it's more common than at least what for me was a bit of a surprise. And if we account for cognitive changes, probably this will be higher, but we didn't look at cognitive changes. So unfortunately, this is another limitation of the study. So we focused on the EDSS, and with all the limitations of the EDSS. So we did not look at hand function explicitly or cognitive function, but for sure, we need to check that. But I think that the proportion of patients with PIRA, if we look at all these domains will increase. Thank you. We are working on that at the moment. Thank you.
Thank you, Carmen. So now I will pick up the question from Emmanuel. We know that body mass index is probably important, for example, for extended doses in natalizumab. So did you measure BMI or did you consider it in your analysis?
So when we first compared the two groups, so SID versus EID, we did not see any differences in BMI. However, when we looked into the BMI of the patients who had breakthrough activity, so they were pretty varied. So like we had 3 patients who had a BMI of around 22, and then 3 patients who had a BMI of 42, and then the other I think 2 or 3 were in the middle. So unfortunately, we were not able to do any further analysis or to see any predictors or associations, just because we had very little events. So we were not able to do that. But this is definitely something to think about later for more perspective, for larger studies later on. Yes, thank you.
I have a question for you, Nicole. Considering, I know that it was not your objective in the study, but considering that there are some information regarding that higher doses of ocrelizumab have been seen to be more protective for progression, have you considered, I assume, analyzing progression in these patients, and how about extending doses? Are you practicing extended dosing in progressive forms?
Yes. So we did look at progression in our cohort, although it was a bit hard to do, just because also, as we know, during the COVID-19 pandemic, there was also some sort of deconditioning that patients experienced, which also might have led to like increasing EDSS, although maybe not really due to progression, but more due to deconditioning. So, and in fact, when I did analyze this part, so RRMS patients did not seem to have any worsening in EDSS, but the progressive patients did have a significant increase in EDSS from but as I said, this could not be directly related to the extended interval dosing, but more so related to deconditioning, because both groups, the SID and the EID patients of progressive MS, did have a worsening of progression. Regarding higher doses, I'm not entirely sure what to think of that. Yeah, but in clinical practice, I think what I've seen here at Hopkins, at least with Dr. Mari, so I think we should always assess, the risks and the benefits of a treatment, and continuously like reassess on a patient like case-by-case basis, like what would be more ideal for this patient, especially now when we look for efficacy of vaccines and vaccine schedule, and especially maybe we should look more into the older population, where maybe immunosenescence can also play a role in like increased risk of infections, and also maybe decreased risk of MS activity in general. So maybe extend, like, I think it's more of a discussion that we should have with our patients and assess risk-benefit ratios, and then ultimately decide what would be best.
Thank you. I completely agree with you. We should evaluate. Anyone?
So I was trying to raise my hands, but somehow I'm failing. I'll tweet slides. So Anna, you were talking about data suggesting that higher dose of anti-CD20 has a better effect on progression of disability. Is there any of the trials that have come out, and I may have missed that?
I'm not sure it's published or it's preclinical data, but apparently with ocrelizumab higher dose, well, it's the study, I can't remember the name, but
because I I know there is a trial right now that is led, but is that trial over? Oh, okay, it's postdoc. Okay, so because I know they were trying to do a trial with higher dose, but I'm not sure that these are completed.
No, it's postdoc, and they're seeing some signal. Again, I think with progressive forms, we should consider other risks such as infection, and they're really something that ends the decision, I think. But we still have to to see the final results. Ellen, I think you want to have your hand raised. Yeah.
You know, the first thing maybe would be to think about whether we think that it really is impacting progression at all in people who start off as progressive, right? And I guess different people may interpret, say, the PPMS trial differently. But I was actually interested, if there are no more questions, you know, or we can put it off to later, but if we have time, in understanding how people are dealing with, like, what at least we saw is pretty massive, like, pandemic associated deconditioning, where in particular our progressive patients definitely seem to get a lot worse than I would have expected during the period of mostly, you know, home isolation or reduced routine activity. And from an epi group of really smart people here, if you're seeing the same thing, either clinically, if you're a clinician, or in your data, and how you're incorporating that into your analyses.
Ruth, if you want to answer.
So I think, Ellen, I would agree that we have certainly seen a staggering amount of decline in people who manage despite having secondary progression for a long time, who used to be I go swimming 3 times a week, I do yoga, whatever, whose exercise evaporated and got worse. I think it may be more than just deconditioning, though, because a number of them are not getting back to where they were before. So I think, you know, what we are seeing about exercise in terms of, you know, benefits for plasticity and repair is that I think for some of them, it's actually knocked them off their trajectories. Some of them, you know, seem to get back, but at some extent it seems to be like how far away they ended up from where they were. And I think the older individuals, you know, were in the 60s, like it's been much harder for them to get back than, you know, the individuals who are 50. What to do about it from an epidemiological, I still haven't wrapped my head around it. I'm also trying to wrap my head around the problem of like the practice effect that you get on like the time walk and the 9-hole peg tests if you do them in clinic. Like, yes, everybody learns it after their first couple of visits, and now you're getting like the practice effect again when they start coming back for their in-person visits. So there's this, you know, they got better, they got worse, they got better, and trying to figure out what's driving that, I think, is going to make a big mess of things, right? It's really hard to unlock because it's so time locked. So I don't have any answers. I just agree with you. It's a very messy phenomenon for any of our longitudinal studies. I'm thinking the simplest thing is going to be to have a variable that's basically like pre or post pandemic, like just to try to adjust for a temporal phenomenon, right? Like it doesn't.
Mm-hmm.
You know, it's just it's a lot of junk, but at least it's acknowledging that there is an additional factor in there that we're having trouble understanding.
Do you think there's any utility in this group, you know, dedicating an extra, you know, kind of think tank kind of meeting at some point to see if we can come up with a solution that might, you know, other groups or we all might employ? I don't know.
It is worth thinking about. I think it's also worth helping, you know, is this an opportunity for us to actually understand on a large, I mean, it's a natural experiment for what does physical activity do for outcomes. So, you know, natural experiments that are, you know, the quasi-experimental can often be very useful. So I do think for that it is worth thinking about whether we can actually use this to really get an answer to that question. And then therefore, you know, can you extend it to people really need to have access to these facilities and resources? Because that could be something that we could learn a lot from. So if there are people who have time and energy to pull it together, I think we should think about it for sure.
Thank you, Ruth, and thank you, Ellen, for the proposition. I think we all saw our patients decline during the pandemic. We were performing also an observational study where the first evaluation was on December 2019, and the second one was 2 years later, including also cognition and quality of life and depression and anxiety. So we have to interpret these results with the pandemic. And this is very difficult. This is very difficult. As Ruth said, this was a natural experiment for all of our patients. And mainly the progressive MS patients will never recover from this. All our patients that became wheelchair, they will never walk again. So this is something that we need to address for all the people here and coming forward, for the importance of exercise. Also, like in aging, the importance of exercise, of making workouts that can be developed at home, developing these multidisciplinary groups for patients and for support, because we might have another COVID or something like that, or some patients may be recluded in their houses for any unexpected reasons. And this is something that we cannot treat with DMTs. We need to treat with physical therapy and with physical touch. So I think it's very, very important to visualize this. So thank you, Ellen, for raising this concern. So I think we are arriving to the end of the session. Thank all of one and everybody that connected today, all of our speakers. We invited you with Anna to present. You can write an email to Anna or me if you want to present, or do you have any question, or do you want to connect with anyone that presented here? Carmen there is leaving her email too, and we hope we can join in about 3 months in another session for this Global Epidemiology Real World Evidence and Observational Studies conference. So I hope you have a great night or day wherever you are.